hosting, and they will be helping us together with our top and our top distinguished experts in colorectal surgery all here. We're going to have this discussion going. So please, Oluwasegun, Olagbaye, please could you go ahead, please? Thank you.
All right. Good evening. Thank you, Mr. Moderator. And my name is Dr. Oluwasegun Olagbaye. I'll be taking the medical aspect of this discussion tonight. Using the following outline. After a brief introduction, we would take a look at the historical evolution of the treatment of appendicitis and review a few of the biases, the dogma, and the general concerns regarding the non-operative management of acute appendicitis, and make a review of current and emerging evidences that supports this aspect of management. And we'll wrap up the presentation with a conclusion. As we all know, acute appendicitis has been a leading cause of acute abdomen worldwide, with a lifetime risk of about 7 to 14%. Out of about 300,000 people that undergo appendectomy each year in the United States, for instance, up to almost 18% are reported to be negative appendectomy. Sorry, excuse me. Sorry, yes. Okay. Although emergency appendectomy is well tolerated by most patients, however, up to 20 to 23% of patients will report with post-operative complications. About 3% of patients that eventually have an appendectomy 10 years after will be readmitted for adhesive intestinal obstruction. It's actually been reported that patients that had negative appendectomy are more at risk of having intestinal obstruction for addition post-appendectomy. It thus lay credence to the fact that avoidance of emergency appendectomy in patients with uncomplicated appendicitis who otherwise will have had surgery would have a risk to benefit ratio of being treated non-operatively. Sorry, I'm having issues. The Renaissance period is actually littered with history of scientists, artists, and anatomists who are making an endeavor to find a name, find description for the organ appendix. It was Johannes Fernelius in 1544 who, upon managing a 7-year-old girl with suspected ceccal perforation, that gave the first description of what looked like acute appendicitis. Well, the name vermiformis was described for appendicitis also in that period. However, we all remember the herniated hernia. Claudius Hermia was said to have conducted the first world-recognized successful appendectomy. However, about 3 years earlier, Coxley was also said to have conducted similar operation in a strangulated hernia. The Sir Parkinson described the progression from initial symptoms. What we now know as the pathophysiology of obstructive appendicitis was first described by Parkinson in 1764. Of a 5-year-old girl who is meticulous documentation of progression from disease to autopsy gave the clue to what we now know as pathophysiology of acute appendicitis. And Thomas Hoskin was the first, having followed the treatment of a medical student who eventually died of appendicitis, was the first to recognize that fecalates are responsible to the obstruction of appendiceal lumen. Okay, and this was also laid credence to by Thomas Addison. I will point out to 2 key historical events that happened in the 19th century that led to the emergence of acceptance of appendectomy as a gold standard management of appendicitis. In 1886, a well-renowned, respected anatomist, Reginald Fitz, reported 250 cases of autopsy of appendicitis from autopsy of appendicitis that was analyzed, and then he alluded to the fact that the death of these patients was a result of peritonitis from ruptured appendix. He angrily would describe the appendix as an unstable, explosive, carelessly left by nature, hidden away in the body of man. He coined the word appendicitis from then and also recommended early appendectomy for suspected acute appendicitis, which gained wide acceptance and momentum as of that era. When Queen Victoria also died, Edward was meant to, just a few days before his coronation as King of England, also came down with symptoms that are suggestive of ruptured appendix. After debates between Lister and Travers, decision was made to operate, eventually had the surgery, drainage of abscess with an appendectomy, and led to a full recovery. These incidents and events were the events that led to the significant public awareness of acute appendicitis and popularized appendectomy, rather than evidence-based decision to make standard appendectomy a standard treatment for acute appendicitis. However, beginning from 1930, Sir Hamilton Bailey, reviewing the work of Washner and Sherring, began to introduce the concept of non-operative management of acute appendicitis with evidences as of that was available then. In 1956, the first reported series of non-operative management of acute appendicitis was done by Henry Cordray. He treated 137 patients non-operatively with only one patient, only one fatal case reported. It was subsequently opined that sometimes wonder whether it would be a sound procedure to treat all cases of acute appendicitis conservatively. They may seem to settle down quietly, and some never have any further for trouble. That's as far back as 1956 that the report of possibility of managing acute appendicitis non-operatively emerged from this work. However, to give credence to this scope of management, there are 4 important trials in the 20th century that began to raise discussion about possibility of having acute appendicitis managed non-operatively. The first randomized controlled trial that was conducted was in Sweden. There were 2 Swedish trials that started the discourse about non-operative management in the 20th century. Stefan Eriksson et al. Conducted a prospective multicenter study in Sweden that had 252 participants, with 128 in the antibiotic group and 124 in the appendectomy group. They will use cefotaxime and tinidazole. Typically, patients will be given 24 to 48 hours parenteral antibiotics, monitor inpatiently, and then discharge home on 10 days oral antibiotics. These patients were followed up. These studies were particularly important because the patients were followed up for at least a year. For the HAPAC trial, which was a Finnish study, it was the first randomized controlled trial that followed up uncomplicated acute appendicitis. The earlier studies, the Swedish studies, were unselected patients, and the men, females were excluded from the trial. The HAPAC studies, which was a Finnish study, narrowed this trial to 550. Over 500 patients were enlisted for a trial for uncomplicated appendicitis that were image confirmed. And in the course of this discussion, we would review the outcome of this study. The largest randomized controlled trial that was conducted regarding comparing antibiotics with appendectomy was a CODA collaborative study, which is an American study that was done in 2012, was reported in 2020. It was a non-inferiority trial that tried to compare outcomes like quality of life, rate of recurrent appendicitis, rate of appendectomy in the antibiotic group in patients, and particularly the CODA trial included patients with appendicolite Unlike the APAC trial and the previous trials that were uncomplicated acute appendicitis, they expanded the scope of patients and conducted this trial. So, what could we say are the biases, the dogma, and the concerns that were against non-operative management of appendicitis? First of all, there is a general belief, there is a general saying in the medical parlance that the appendix is a vestigial organ without function. Also, the pathophysiology of acute appendicitis has been naturally reviewed as being obstructive and should be managed surgically. Also, there were concerns if antibiotics will actually cause resolution of acute appendicitis, questions about early and late recurrence, post-operative complications for non-operative management, length of hospital stay, and also the risk of missed neoplasms in patients, quality of life of this patient and patient satisfaction, and of course, the economic implications of having to have patients treated non-operatively. These were general scope of concerns against non-operative management of acute appendicitis. What are the current evidences? The discussion around the appendix being an organ without a function is being put to bed with recent evidences. There is a safe house theory that suggests or that has found that the appendix hosts a dense mucosal biofilm of commensal microbes. These microbes were said to help in repopulating the large intestine to maintain the beneficial gut flora after disturbances like in diarrheal diseases. For example, it has been noted that patients who have had appendectomy before have a higher risk of having a recurrence of Clostridium species infection for having the reserve of commensal bacteria or microbes that have been taken away on an appendectomy. Also, we would also affirm to the fact that the appendix have been attempted in use for many reconstructive surgery, tubal surgeries, ureteric surgery, but surgeries that have lasted the most were the continence surgeries, reconstructive surgery like the Mitrofanov's procedure, and also the antegrade continence enema procedure. Rethinking the disease as we know it. Appendicitis historically has been thought to result from luminal obstruction with ficcolith, distension, bacterial overgrowth, increased luminal pressure, and progressive tissue compromise and gangrene. However, more recent studies have attempted to measure the luminal pressure in patients with appendicitis and have shown that the increased pressure is only available in a quarter of patients that naturally are presented with features of appendicitis. There is also a study that has shown that ficcoliths were only identified in 18% of patients with appendicitis, while 29% of those without appendicitis actually carry ficcolith. So it raised the question, is ficcolith, the obstructive appendicitis, responsible primarily from ficcolith? Appendicitis as we know it is a natural progression, natural pathophysiology of appendicitis as we know it. Is it what it is? There is growing evidence to suggest that perforation is not necessarily an inevitable result of appendiceal obstruction. That perforated appendicitis and non-perforated appendicitis are different clinical entities and so should also be managed entirely differently. So with this renewed understanding, the pathophysiology of appendicitis has raised an important need in evaluating the potential of an antibiotic-first treatment strategy. Resolution with antibiotics. The earlier studies are mentioned, the regimens typically used in those studies were broad-spectrum anaerobes covering antibiotics parenterally for 24 to 48 hours and orally for 10 to 14 days. The Swedish trials reported 80 to 90% of efficacy of antibiotic treatment and resolution of symptoms of patients treatment in the antibiotic group within 48 hours. While only 5.8% of the APAC trial failed to resolve within 48 hours and eventually underwent appendectomy. That's over 95%, almost 95% of patients in the antibiotic arm had resolution of symptoms within 48 hours of commencement of antibiotics.
Yes, sir. Okay, please, just a moment. We will need you to start rounding off, okay?
All right, sir.
Because we still have the rebuttal and debate. Thank you very much. Thanks.
With concerns for recurrence, the CODA trial also reported about 29% of recurrence within a year. And these outlines for the APEC trial and CODA trial actually had an extensive follow-up of patients for almost 10 years. And averagely, less than 40% of patients eventually will have one form of recurrence, which also reduces as the year progresses. Major complications were 3 times more higher in patients who had surgery compared to patients that have antibiotics. And those complications like small bowel obstruction, abscess, reoperation, which is not present in patients with antibiotics. So during this period, about 14% of patients in the surgery group had complications compared to the antibiotic group. And as we'd expect, the overall treatment and economic of managing patients with surgery is actually found to be cheaper to manage patients with antibiotics compared to surgery. Patients with surgery, patients who had appendectomy straight away tend to stay more in hospital, stay more out of work, and so have overall economic impact on patients. Also very important is the risk of missed appendiceal tumor. There is a study that reviewed over 2,293 appendectomies and found that just 1.6% of patients had malignant or pre-malignant lesion. And those lesions were non-aggressive tumors. And they are also commoner in patients who are 60 years and above. And in this review, it was found that over 85% of these patients will have qualified for non-operative management, will have been eligible to have antibiotics as treatment. This supporting oncology safety of non-operative management of antibiotic of appendicitis. The quality of life in both group of patients were no different. So I would close. The appendectomy became standard goal of care largely through practice and plausible reasoning long before we had randomized trials. The historical part explains why surgery was accepted rapidly, but it does not mean it is always the only evidence-based option. Over the past 2 decades, with the quoted trials, we have had has consistently shown that patients with image-confirmed uncomplicated appendicitis can be managed non-operatively. Antibiotic-first approach is reasonable. It's evidence-based option for selected patients. It is an informed choice and is not an ideological shift. It is safe to offer antibiotics as a first-line option for eligible patients through shared decision-making, explain absolute risk of chance of early recurrence. However, set up strict follow-up with low threshold for operative intervention. Thank you.
Thank you very much, Dr. Oluwasegun. Great job you've done. Please, can you take your slide down very shortly so that Dr. Bilal, Mohammed, Issa can come on board, please. Thank you very much. Great job. Coming from our senior registrars who are going for their fellowship program in general surgery. Please take down your slide. On share, please.
All right, sir. I'm doing that.
Okay. Just click stop sharing. Yeah. Okay.
So we're introducing Dr. Bilal Issa Mohammed. He's a fellowship resident at the Federal Teaching Hospital, Gombe, who'll be taking up the surgical management of acute appendicitis. Dr. Bilal, welcome on board.
Thank you very much, sir. Good evening, moderators. Good evening, our consultants, professors, and faculty here present. I will be presenting on appendicitis, the final showdown. I will be defending the position that surgery still remains the standard. We'll be taking this outline. We'll be going through the review of current evidence. We'll be comparing the medical versus the surgical management, then appraise major randomized control trials, as my other co-debater has done, and then we're going to defend appendectomy as definitive treatment. So, we are looking at the burden of disease. Appendicitis remains the commonest surgical emergency. It has a peak age of 10 to 30 years. Then the lifetime risk is 7 to 14%. And it has a significant burden, most especially in the low and medium income countries. most of our presentation or most of the presentation of our patients are usually the complicated appendicitis. This further portrays the importance of early surgical management, most especially in our own region. So the pathophysiology has already been touched on by my co-debater. The treatment options basically range between the medical, that's the antibiotics, plus or minus observation, and then surgical. Surgical has the open and then the laparoscopic appendectomy, which is what is most favored currently. So appendectomy remains the definitive, curative, and most reliable treatment. Although we cannot completely push away the fact that antibiotics have a role in selected uncomplicated cases. But this does not mean that antibiotics can replace surgery as the standard of care for patients with acute appendicitis. So why are we supporting the position that surgery wins? Because surgery affords us definitive cure. Once patient has acute appendicitis, once appendectomy is done, preferably through the laparoscopic means, which has lower complication and then has almost zero recurrence. So that offers definitive cure for life for that patient as regards to acute appendicitis. And then it also gives us the opportunity for source control. Sometimes what may not be really visible during imaging may be apparent during surgery, and we can be able to do some source control by taking out the inflamed appendicitis and then also some drainage of periappendiceal fluid. That also has no recurrence, as I've earlier said. And then histology, as my co-debater earlier mentioned, that it's not all cases of patient presenting with right iliac fossa pain or presenting with what looks like appendicitis on imaging tends to be acute appendicitis. Sometimes there could be coexisting parasites, most especially in our own region. We can see sometimes schistosomiasis that is found within the appendicitis. This affords us the histology to be able to administer a definitive cure for these patients. And then patients can also have carcinoid of the appendix. They could also have adenocarcinoma of the appendix. This can only be diagnosed through histology. And then giving a percentage of individuals come down with cancer in patients that were managed earlier for with antibiotics for acute appendicitis. This percentage, no matter how small, represents human life. It has also brought applicability, and then it also has improved quality of life, because a lot of these patients, as we're going to see, if offered medical management, quite a significant number of them do represent to the emergency units or to the surgical clinics with features of acute appendicitis necessitating appendectomy. So the APAC trial is part of the randomized control trial that we're going to review. So as my co-debater earlier mentioned, he has given a highlight of what the trial entails, but then significantly what I am going to measure on here is the fact that 39% of patients that underwent this trial required surgery by 5 years. So this means that this patient represented ultimately, after having had medical management, to have appendectomy done by 5 years. And you will all agree with me that appendectomy in these cases tends to be a little bit more difficult because of fibrosis and scarring. And then also recurrence remains a major limitation, which this trial has also mentioned. The CODA trial, which is the comparison of outcomes of antibiotic drugs and appendectomy, it also shows that antibiotics were non-inferior in the short term in selected adults. However, 30% of patients had appendectomy within 90 days. And then also the outcome was significantly worse in patients with appendicitis. So this further supports the early use of appendectomy, most especially in our region where the diagnostic instrument might not be readily available. Also, I'm going to bring this story, which is a 3-year follow-up of antibiotic spices surgery for acute appendicitis. This study was recently done. It is a retrospective study that looked at patients who had acute appendicitis and were treated using antibiotics. It found that 42.6% still had recurrence within 3 years of treatment. And then neoplasm was missed in 3.5% of cases. This 3.5% of cases represent life and represent patients coming back with morbidity that might have earlier been tackled with appendectomy. So why do we think antibiotics fall short of appendectomy in management of acute appendicitis? Because with antibiotics, the inflammation might still persist, and this may lead to more pain and then decreased quality of life. And it will also take away 1 hour of the patient. The patient might have otherwise been productive elsewhere, so these patients might be placed on long period of observation within the hospital. It has more recurrence, as we've already mentioned earlier. It has a higher rate of readmission, which also may add to the cost of care. And then invariably, for a lot of patients, giving antibiotics is just delaying the surgery of that patient. So modern laparoscopy stands to obviate most of the complications that are associated with open appendectomy, because it offers minimal pain, and then it has a short duration of stay for the patient, and then it has early recovery, where with patients being discharged within 24 hours of surgery when there is no complication. It also has better cosmesis. All these societies, which societal guidelines, which all agree to the fact that antibiotics are an option for selected uncomplicated cases. However, appendectomy remains the definitive goal. So we've already had my colleague mention that antibiotics avoid surgery. Of course, they avoid surgery, but in most cases, they just delay the surgery. It has a lower complication, but then these complications are offset by the fact that a lot of these patients come back with recurrence. And then some patients may say, we may argue that some patients may say that they do not want surgery, but a lot of patients prefer certainty. So in conclusion, appendectomy provides definitive cure, source control, pathology confirmation, and then prevents recurrence. The scaffold still triumphs where certainty, source control, and cure are required. Thank you very much.
Thank you so much. Great job, Dr. Bilal Mohammed Isa, for Federal Senior Registrar Fellowship and Surgical Trainee, Federal Teaching Hospital Gombe, for taking on the surgical management of appendicitis. So we have the two debates here. Do we do medical management or do we do surgical management, and in what situations? At what point, as surgeons, when we finish and we've made the diagnosis of acute appendicitis and we see the patient goes to surgery for safety purposes and the patient refuses, and he would want conservation, and we keep doing the conservation and it's not working, at what point do you tell the patient you can't proceed with his management and refer to another surgeon to continue with the management? So I'm handing over to our international rapporteur, Mr. Emmanuel Eguare, to help us moderate the debate. Other people can join in the debate as we go for this very important topic today. So Mr. Emmanuel Eguare, please. I crave your indulgence, sir. Thank you very much.
Thank you very much, Dr. Enemo. And thank you so much, and Dr. Oluwasegun Olagbaye and Dr. Bilal Mohammed for your very erudite presentation. And I think both of you have presented very eloquently as to why we should be adopting medical or surgical options for the treatment of appendicitis. And in fact, you guys have left me on the borderline now. So you should win me over with your argument. So I'll let you do that. But I will welcome questions from the chat room so that we can ask the questions. And please, if you're asking questions, can you direct it to the proponents of both options so that they can answer the questions? And my first question to Olusegun will be, being a surgeon, well, and I think I appreciate the data you have presented, but when I look through your historical perspective of the very prominent people, I mean, when they did a randomized trial with intention to treat, particularly the sad cases of the medical students who died, I mean, that was in an era where ethics still allowed them to do that. And you saw that it was a certain death for patients that progressed to perforation. So what will you say to that? I also see in your conclusion, you did allude to the fact that we should have a low threshold for adopting an operative option should medical option fail. So what do you say to that, knowing the certain conclusion or the definitive pathway journey of a patient that is put in this pathway of medical management? Olusegun.
Thank you. Thank you, sir, for the question. Okay. This is it. Medical management. What I would say is that we should. I mentioned something about the fact that we need to start considering the evolution of our practice. It's a consideration to know that if for instance, in the CODA trial where you have about 700, almost 800 participants in the antibiotic group, and over 400 of them could escape surgery. Now, for those who eventually had surgery with close monitoring, 24 to 48 hours of high parenteral antibiotics and observation, when there is no resolution of symptoms within 48 hours, you progress to surgery. And then even patients who eventually will come back with recurrence, more than 85% of them are not presenting with complicated appendicitis. So it is still a safe approach, particularly where we now have good imaging compared to the times where the medical student, like you alluded to, that way we have less imaging technique and follow-up means to be able to know which patient will progress to surgery and which patient will benefit ultimately. The less we get and the more number of people we could get out of surgery, the better. So long as we're able to monitor this patient, my colleague was talking about long stay. Observation typically is between 24 to 48 hours. After that, you could make a decision. Is this patient progressing progressing with non-operative management, or you move into operative management? Okay, so I think imaging, close monitoring and follow-up, and the fact that we have evidences to show that these symptoms, even with the fecal, even the CODA trial where you have fecolates, a significant portion of those patients still get away without surgery. Okay, so I don't know if that addresses the question, sir.
That's great. Thank you very much. I think you've answered my question. But then the next question here on the chat counters that a bit again. This question from Xiaomi, it says, thank you for the presentation. what is your opinion on the non-operative management of uncomplicated appendicitis in resource-limited setting, like Nigeria, where abdominal CT is the gold standard for perioperative diagnosis of acute appendicitis, which may not be readily available or affordable? It says this is important because there is possibility that those that manage non-operatively may not necessarily have acute appendicitis in the first place. So this again buttresses the question, or what you were saying, that the advent or the the evolution of diagnostic radiological diagnosis has helped in deciphering who should be managed medically and who should progress to surgical intervention immediately. So, considering the affordability, consider the cost of straightforward appendicitis and the cost of going to have a pre-diagnostic CT scan to determine if a patient should go down the route of medical management, and then the cost of the antibiotics on top of that, the cost of the hospitals on top of that. What do you say? What's your argument on that?
Okay. Thank you. Now, we do not need a CT to determine who will have surgery or not. If a diagnosis of appendicitis is made, either even in a low resource setting, so long as you are able to make a diagnosis of appendicitis with whatever image modality that you have, the decision to decide if the patient should have medical management or non-operative management now depends on what spectrum of disease do you think this patient has. Like I was saying in the presentation, patients with complicated appendicitis, of course, you do not want to consider them for non-operative management. But when you have uncomplicated appendicitis, from your decision, either ultrasound scan or whatever you have in the low resource setting, ultimately, it is cheaper to make that patient avoid surgery than to give the patient a surgery he could actually avoid. Measuring cost, measuring ultimate cost depends on how you look at it. If you look at it on the immediate term, and then if you have to subject everybody to knife, what will you say to 23 to 30% of patients who will eventually come down with adhesive small lobular obstruction if they could have avoided surgery? And like I said, the fact that patients come down with recurrence does not mean they are coming back with complicated appendicitis. That's what the data said. The data that said the fact that you give a patient a chance, if the patient resolves with antibiotics in the first few hours of admission and patient was discharged home, oftentimes, even if there is recurrence, chances are that patients are not coming back with complicated appendicitis. So we have nothing to lose to give them a benefit of the time, particularly in low resource setting, where actually to go through surgery is cheaper than a 2 weeks antibiotics regimen for a patient that will eventually escape surgery on the long run. So it depends on how we look at it, really.
Great. Thank you so much, Dr. Oluwasegun Olagbaye. I think you are really defending this role very well, and I appreciate that. Just one more question for you before I move to the next question. And there's still a question there. Do you still consider those with confirmed ficolate on imaging as non-operative management? That is, if a patient is fortunate to be able to afford imaging and is sure that this patient has an obstructive ficolate in the appendix, will such patients still continue on medical management, or should those patients be committed to the surgical management?
Thank you very much. I would say that with patients with ficolate, the CODA trial were bold enough to add patients with ficolate, and as expected, most of the recurrence, more than 40% of patients who came down with recurrence patients who came down with recurrence were about 40% of the patients who had ficolate ab initio. So it's been found that it increases the likelihood of recurrence. But again, I think we will need to treat the patients patient by patient basis. These decisions need to be a shared decision. Honestly, one of the intriguing things that was discovered is that patients who were given opportunity to have non-operative management and who eventually came down with recurrent appendicitis and had surgery subsequently.
Dr. Oluwasegun, we seem to have lost you there. Okay, while we are waiting to get him back, I'll just read the next question and maybe I'll ask Dr. Mohammed to help
Again, many of them to go through the route of non-operative management, even him. So I think current patient by patient basis and let the patient know that, okay, if you have appendix, the chances are that you will have a likelihood of recurrence. Okay, and of course, if patient is not progressing in the early phase of the treatment, then you know you need to progress. But to subject all patients with diagnosis of acute appendicitis.
Okay, I think we are losing Dr. Oluwasegun. Dr. Rowa, you have your hand up there. Do you have a comment there, Dr. Rowa, before we go to the next question on the chat?
Yeah, yes, I have a question.
Yeah, go ahead. Yeah,
I think it is time we start our
you can
decision.
never
I
controversy
do not want to use
any
for
of
Okay, and Dr. Oluwasegun, I think you are going in and out. So Dr. Irowa wants to make a comment just in your support there, I think.
So I think
yeah, go ahead.
We can never controver the fact that, these are very important information that have been passed to us. But if you look at both sides of the argument, both of them actually, if you put them together, in short, at the particular day, there's a meeting point for both of them in the argument. And for every such severe pain, and tell you, oh, I need to go and come back. It's like, okay, let me place an antibiotic, you come back a few days' time. But, all of us, I may have had a personal experience of patient who came to the hospital giving antibiotics, came back with complicated appendicitis. These are all stories, but even going forward, acute appendicitis. If you choose at a particular point in time to go the route of antibiotics at the first time, you should be able to monitor the patient appropriately. So that at that point in time, in our setting, a patient don't come back, usually don't come back to surgeon.
Great, thank you so much. Dr. Lassie, can we stop the...
Ask the patient who have a pain in the right ear.
Yeah, thank you. Yeah, Dr. Rowa, are you still there?
Yes, I'm still here.
Okay, the line was just going on along. Yeah.
Sorry, I was just saying that the surgeon should take primary responsibility of managing this patient. If you have the route, you must be able to follow up. But the challenge is that it's extremely difficult sometimes to have patients coming back and follow them up to know what they have.
Hello?
Or the problem they have at the point their is made. Sometimes they may end up developing complications that you yourself will not look at. Oh, I should have taken.
Yeah, I don't know if it's just me that the signal seems to be going up and down. I don't know.
No, it's not. It's not just you.
Okay.
It's not you. It goes and comes.
Okay. All right. Okay, so we seem to have lost Dr. Rowa, but I think we got the gist of his view there that most of there's a congruence of opinion here of both the debaters or both proponents here in terms of what we eventually do. And I think the rebuttal from Dr. Ibrahim Mohammed also, or Bilal Mohammed also is helpful there. Dr. Okpadeyi has his hand there, but just before you do that, I want to say, and Dr. Nemo, will it be possible for us to carry out a survey at the end of this based on everybody's opinion? What do we advocate for? Medical, surgical intervention or in between or a hybrid, so that we can have a view or a vote based on the arguments we're having tonight.
Yes, we'll do that. I just put it down.
Okay. Yeah, before I call Dr. Padei, there's a question here by Dr. Nemo. It says, if a patient refuses appendicectomy after my clinical diagnosis and is not doing well with conservation, please, Dr. Oluwasegun, at what point should I refer to another surgeon? Well, maybe just for sake of time there, my question would be, if he refuses your view, a very respectable surgeon, what makes you think another respectable surgeon will give a different opinion? And the chances are that this person will go to a hack somewhere,
Yes.
yeah, which will even make the situation worse. So I don't know what chances of survival this person will have if they refuse your opinion. That's my view there. Dr. Padei. Yeah, Dr. Padei, you are muted. Can you? Yeah.
Yes, I have admitted. Thank you very much. I first want to appreciate the two presenters and the fact that their presentations were evidence-based and very well presented. However, the key point that I felt was not adequately approached was that statement in selected patients. How do we select these patients in this environment? And I'll try and illustrate. We all know that appendicitis is primarily a clinical diagnosis. And an ultrasound as a diagnostic tool is not very reliable, especially as it is dependent on the skill of the sonographer, one. Two, even with a skilled sonographer, the appendix may not even be visible, especially if it's a retrocecal appendix where the air in the cecum will prevent visualization of the appendix itself. Therefore, the only reliable imaging modality for diagnosing appendicitis, in my opinion, is probably a CT or an MRI, which is not available, especially as regards the price point for most of our patients here. I work in a government hospital in Nigeria. Therefore, that makes it difficult to back up your clinical diagnosis with sufficient radiological proof to be able to justify offering a patient antibiotics alone. That's one. Number two, the obstruction is not always due to a ficolite. I have found in operating many patients that the point of obstruction may actually be an adhesive band, either from a previous bout of abdominal pain, which may or may not be appendicitis for which the patient took antibiotics, or maybe a previous pelvic pain. So that adhesive band causing obstruction, causing appendicitis, again, I think what we describe as the subacute appendicitis, will not necessarily have a ficolite associated with it. So an obstructed appendicitis does not always have to have a ficolite, making it even more difficult to decide which patients are more likely to respond to just antibiotics or those who would need surgery. I will give the rest of my opinion when we are all asked to express our own practice at the end of this. Thank you.
Okay, thank you very much, and Dr. Padei and Dr. Nemo. Yeah.
No, sir, it was on the previous question. Sorry, I'll lower my hands now.
Okay, all right. Okay, thank you. And Dr. Nwonsu Evan says, what's your opinion in use of antibiotics for patients in Nigeria where most patients would have self-prescribed antibiotics before presenting? Do they still merit non-operative care? Or there is a history where there's a history of antibiotics already? Yeah, I guess, again, when you're randomizing patients into this I mean, this is a very cogent question. If a patient has used antibiotics at home and failed already before presenting to you, is that enough to say this patient has failed and should be considered for surgery or not? And Dr. Bilal Mohammed, do you have a view on that?
Thank you very much, sir. The most of our patients in our region present mostly after taking antibiotics that they must have self-prescribed to themselves. They may have taken a lot of concoctions before even presenting. So a lot of the times, even the way the patients present do not follow the typical natural history of the patient, sometimes making diagnosis even more difficult. And oftentimes than not, patients do, because they take these medications that they self-prescribe for themselves, they usually present late, making, another round of administration of antibiotics, if let's say seem like counterproductive. So I think with that point, that will even support more of the immediate surgical management rather than the medical management, sir.
Okay, and Dr. Rowa, you have your hand up there.
I was just saying that I think I'm very much interested in the survey because some of the issues that have been raised actually is good for us to look at what we normally do in our area and the choice why we made that choice. By doing a survey, we help us a lot that we can also put our footprint on so many of those issues. I just think that I completely support it. If yes, maybe after this meeting, we can actually draw a question and survey the geopolitical zone in Nigeria and see what people's opinion are. But in that survey, there will be a lot of very important questions as to how the patient, how many days the symptoms are there, prior medication taken before that time, and the choice of surgery, sort of doing surgery, and why the surgeon took that decision. And just for let the surgeon take his own opinion on it, then we can get something out. Then that's one level. The other levels are, I'm just suggesting is that we can go back and find out from our various centers and can find out most surgeons, how many who have tried antibiotics use and what their outcomes are. If we get enough from our own place, we can make comments on it, even though it may not be a real trial, but we can look at the practices and see whether it can become a basis for us to really do a trial within our locale. Thank you, sir.
That's fantastic, Dr. Roa. Yeah, so why you've just said is at least there are at least 61 to 67 people on the platform now. Can I just say maybe Dr. Roa, Dr. Olasi, and Dr. Nemo, if the three of you can come together to design a questionnaire for this survey and circulate to every member of the association and see what the respondents will be, the response, so that we can collect that. It's going to be an interesting survey. So do I take it, Dr. Nemo, that you coordinate with Dr. Olasi
and Hirua? Yes. We'll do that.
Yeah, we can put together a questionnaire and circulate that.
Thank you. We'll do
okay. That. All right. Thank you. There's another question here from Dr. Zayomi. For the presenter for non-operative management, what would be your criteria to abandon non-operative management of uncomplicated appendicitis? Again, Oluwasegun, the questions seem to be coming to you.
Thank you. The criteria, no resolution of presenting symptoms after 48 hours of commencing parenteral antibiotics. Okay. In fact, I think the part 2 or 3 trial now, they were even trying to use outpatients. I think there's one of the trials that has gone on to attempt to treat outpatient. But the studies that I've quoted is patients are observed, even to answer some of the questions and concerns raised about at what point do you make a decision and all of that. You have a patient coming in the first 24 to 48 hours of commencing parenteral antibiotics. As a clinician, you monitor the patient. If pain continues, there is no resolution of symptoms, there is worsening abdominal pain, there is features that looks as though these symptoms are progressing, then you know that you are not winning with antibiotics, and the chance they are giving this patient is over. So the talk is about antibiotic first. Can we consider antibiotic first before progressing to surgery, even in low resource setting? It has actually been found, even in studies, that the fact that patients are given antibiotics first in inpatient does not increase the risk of perforation for a patient that are come with non-perforated appendicitis. So to allow patients to try out antibiotics in the first few hours of admission is not likely to worsen the outcome of the patient, even if the patient progresses to surgery.
Okay, thank you very much. The other question there's a question there that says, what determines progression? What would be your modality for monitoring, considering the cost of CT scan? My question to you there is, you keep insisting on the close monitoring. The full blood count, inflammatory markers like the C-reactive protein, do they have a role to play in this, or all the other parameters, monitoring patients' heart rate, temperature, abdominal tenderness, and all that? What is your package, or what are the parameters you use for the close monitoring of these patients?
Thank you, sir. Very well. The parameters as you have listed, clinically and also laboratory. WBC is rising from what you have at admission, and you're not winning the C-reactive protein. There is a study, I can't recall that study now, who uses a certain value of C-reactive protein to even make a decision to know, okay, these patients are not going to progress. And like I said, I think we need more studies on these parameters to even be able to say, oh, patient coming at this level of C-reactive protein, you know this person is possibly not going to progress not going to do well with antibiotics straight away into surgery. But we do not have enough data or volume of studies in that regard. But we could use clinically WBC and all the parameters that are available laboratory to measure up if patients are improving or patients need to progress to the surgery group.
Okay, thank you so much. Okay, Dr. Agbola, thank you for identifying yourself. I gave you a new name there, Xiaomi, but now Xiaomi is Dr. Agbola for the record. Thank you very much. Okay, there's a question from Dr. Lassie here that says, thank you, debaters, for putting up excellent defense. For Dr. Bilal, what would be your advice in a patient with radiologic evidence of acute uncomplicated appendicitis with clinical improvement on antibiotics and analgesia? Dr. Mohammed, any question?
Thank you very much for the questions. So yes, as I've earlier mentioned, if a patient is doing well on antibiotics and analgesia, then of course that patient is entitled to be offered the medical management of the acute appendicitis, because it is non-invasive. In as much as surgery is definitive, the medical management is non-invasive, and the patient can be told that the antibiotics and analgesia seems to be working, and he will be observed, and if everything is fine, then he can be discharged to follow up. And he should also be counseled on the fact that he has had antibiotics and analgesia, which seems to have worked. It does not negate the fact that he may have recurrence in the future. So that's my response to that. Thank you, sir.
Okay, thank you so much. And I know for want of time, I think that's an excellent response to that. I just want to read a comment from Dr. Ademola Agbaye, and I will maybe recommend also, I think all the comments, questions here should be compiled for just the benefit of everyone, particularly for those going for exams. I think this is a very good resource you should just consider. So if we can collate all the comments and the questions at the end and just put them together as a package and circulate for all the members, just to as a resource.
All right. Thank you. Okay, I will just make reference to a study by Maxine Gemis, who analyzed about 2,293 appendectomies and found that just 37, that's 1.6, had malignant or pre-malignant lesion, and about 0.3, which is 8, had benign non-dysplastic lesion. And it is also noted that in this patient with this malignant lesion, they are 60 years and above. They are older patients, which typically we will not even, they don't fall into the age group that we will use clinical. In our area here, you use ultrasound scan to make a decision of acute appendicitis. You want to investigate them properly to be sure that they do not have tumor. And so the risk of missed neoplasms in this patient is less than 2%. Okay, and in those 2 patients, we are talking about older age groups, which with good investigations, even on the imaging, you could know. I think MRI or CT will talk about a diameter of more than 15 millimeter. You should be suspecting neoplasms. Okay, thank you.
Thank you very much. And it's also instructive to know that some of these patients that are found incidentally, most of them are neuroendocrine tumors. And so we should bear that in mind, and also that the tumors might just be so minute that they haven't been diagnosed on imaging, but they are incidental finding on histopathology, and they are not symptomatic at that stage. So We should just bear that in mind also. Dr. Peter Abba has a question here, and it says, thanks to the two, considering the economic reality, the fact that the majority of our patients still pay out of pocket, does anyone have any data of the mortality from non-operative management as compared to operative management? Please, if you have the data, can you just signify by a raise of hand, and I will call on you to comment on that. And while we are waiting for that, I will go to a question or a comment by Dr. Augustine Iratulan. And it says, in our setting, we offer conservative stroke antibiotic management to pediatric patients if there is no evidence of complicated appendicitis. We have also had cases of resolution after antibiotic therapy, but of uncomplicated cases. Yeah, thanks, Dr. Ratulam. I think, again, in pediatrics, I know that lymphadenitis is a very common cause of symptoms that will mimic appendicitis. So I think it's worthwhile considering the non-operative management, particularly in the pediatrics, and particularly in females who may present with symptoms akin to appendicitis on the right side, and where imaging is not available. You should be guided by some blood parameters like the inflammatory markers and white blood cell count. But these are things.
Let me also congratulate our presenters. They defended themselves very well.
Thank you so
That's
much.
great.
That's Dr. Ratulan from Italia. Thank you so much. Good evening. Yeah, and then Dr. Anne Olute. Thank you for the presentation. From the presentations and answers, it actually appears that it is more expensive and burdensome to manage the patient non-operatively than an operative management. That appears to be a quick, definitive management. The operative management all seems a better choice in our environment. Thank you. So Dr. Anne Olute has voted. And I will encourage you to put that comment in the survey when we send it out. That's very emphatic. Thank you so much, Anne. And then Dr. Bashir Ma'a is thanking everyone for the good presentation. Dr. Olasi thanks everyone for the active participation and is encouraging all of us to complete the attendance register. So in the absence of any more questions, and I think I want to thank everyone for such an interactive session and very engaging. I think the attendance heard all through. So I thank you all for participating. It just shows how a topic such as appendicitis can really stimulate such an interesting conversation. I think it's been a learning point for all of us. And I want to thank the two presenters who did their research, presented with literature, with evidence. And I thank you all for tonight. And I'll be handing back over to Dr. Vincent Enemo to round up. Thank you very much.
Thank you very much, Mr. Emmanuel Egara, International Rapporteur, for expertly conducting this very important topic. A few thanks to you, sir. We're grateful. And we also made the promise that we're going to share the questionnaire in the group page so that people can submit what they do in their practice. So they will now put up a memo to the entirety of our people here so that we see what we're doing. We're going to meet again on the 29th of August for our next presentation, and then also to do the OGM, which was postponed to that because of technicalities. So thank you, everyone for coming around. Thank you, Dr. Bilal, Mohammed, and Dr. Oluwasegun Olagbaye, our fellowship candidates who had made great presentations today, well researched, well packaged, and we are grateful. And we want more of our residents to also present this way once in a while. It is worthwhile. Thanks everyone for coming around, and we'll see all of you next time. Thank you. You have a nice day.